sharing this fascinating research with us.
Thank you very much. Okay, thank you one more time. And now we can continue. And I would like to welcome Dr. Duncan McLauchlan. He is a consultant neurologist and senior research fellow affiliated with the Division of Psychological Medicine and Clinical Neuroscience at the Cardiff University. And he has an excellent academic background in neuropsychology and epidemiology. He's a member of the Behavioral Working Group of the EHDN, and he will continue and will talk further about the neuropsychiatric symptoms in HD, and will present some of his very exciting data about the management of HD, pharmacological management. Please.
So first of all, thank you very much indeed for the honor of being asked to speak here. It was a complete surprise, and I feel like there are many other people who could do this much better than I could, but thank you all the same. I was asked to give a biography for this, and I was tempted to just put I'm a neurologist that's gone a bit rogue, because I got interested in the behavioral changes of the disease during my PhD. So just to give an overview of the talk, I wanted to start with some caveats and to avoid disappointment. Talk about some of the common problems that people experience as part of the psychiatric phenotype. Cover the current recommendations, so I feel like I have addressed at least some of the management. And then look into why people get psychiatric problems as part of HD. Look at, are these psychiatric disorders in HD different from those in the general population? And then look into what should inform decision-making about treatment, and hopefully propose a model for progress. So first of all, as I've said, I'm neither a psychiatrist nor a psychologist. So if you're expecting the kind of nuts and bolts talk about we've tried mirtazapine and doxapine, we're next, I think you're liable to be disappointed here. But in my experience, life is full of disappointment, and anyone who says different is selling something. So I should also say as well that this is a very biology kind of focused talk, and that's not to disregard the importance of cognitive therapy and psychological intervention, but it's just to say that's not my area of expertise. But it is to say, to emphasize that that is a really important aspect of this. Right, so I've been gazumped, so I won't belabor this slide in detail, but it's just to say that actually, psychiatric disease is part of HD. Apathy, deficit in goal-directed behavior starts early, starts pre-manifest and progresses with the disease course, and that's shown not just from Eric Van Duyn's data, but also from the Track HD study and a number of other papers by David Crawford. But there are higher rates of a number of different symptoms, so depression, anxiety, and in this slide, which used the UHDRS behavior, it talks about obsessive compulsive behaviors, but I think we probably recognize now that that's more perseveration. So OCD is an intrusive thought which makes you repeat a behavior because of fear of something that might happen, whereas perseveration is inappropriately repeating a behavior without almost realizing that you're doing it. So what are the current recommendations for treatment? So this is a systematic review from 2019, and they used a process similar to the Cochrane process, so they appraised the level of evidence before going ahead with a Delphi process, so cycles of what's important among a group of clinicians and also patient representatives before deciding what to include in their final recommendations. So for depression, they recommended an SSRI or an SNRI first line, mirtazapine if there were sleep problems, involving psychiatry early if you run out of options, and considering ECT for refractory cases. For irritability, again, an SSRI first line, neuroleptics if aggression was a problem, and thinking about sedative antidepressants for comorbid depression. And then finally, for apathy, I suppose the conclusion could be we don't really know, not much works, but stopping sedating drugs, which could potentially worsen apathy, and considering treating any comorbid depression. I think what's most striking about this is that it's all derived from that Delphi process. And so the only paper that was included in the evidence base was the citalopram for cognition, which excluded people with significant depression at baseline, but still found a reduction in depression scores in the intervention group. So really, actually, there's not a strong evidence base to base treatment recommendations on. So I think the next area that I wanted to cover was, why do people with HD get higher rates of psychiatric disorders compared to the general population? So I think the obvious thing to think of is actually there are a huge number of environmental factors. People have watched their parents being ill. You know, some of them will have been carers for their parents. And then later in life, you know, recognizing their own genetic at-risk status. And then in adulthood, we recognize that there are higher rates of addiction, you know, poverty, and then because of the nature of the cruel nature of the disease itself, they have reduced social and family support. But there is also a biological component to this. So don't worry, there isn't a neuroanatomy quiz at the end. But there are definitely areas that of the brain affected by HD that are involved in, you know, mood, emotion, behavior, cognition. I think many people, or if not most people in this room will know that, but, you know, the caudate involved in learning from reward and learning from losses. The anterior cingulate cortex is involved in cognitive control and switching, which is important in extinguishing unimportant behaviors and activating relevant ones. The amygdala is involved in emotional memory and in fear conditioning, so potentially has a role in both aggression and in anxiety. But in reality, this is a smoking gun. You know, we know that those areas are affected, but do they contribute to the pathology over and above the effect of the environmental factors? So there are a couple of really lovely and important papers which I feel sometimes don't get the recognition that they deserve. So this paper from David Crawford's group back in 2007 in JNMP recruited people attending for predictive testing. So they excluded everyone with motor symptoms, and they recruited 204 people and measured the composite diagnostic interview at the outset, specifically looking at depression. And they found higher rates of depression in gene carriers compared to non-gene carriers. And then this slide is drawn from the Pharos study. It's published by Caloran in 2013. Now, this was an even bigger sample of nearly 1,000 people. And again, they exclude, so this is an at-risk group. Everyone had an affected parent or close relative. They excluded anyone with significant motor or cognitive symptoms at baseline, and then used the UHDRS, motor, cognitive, and psychiatric scales, whilst also testing people to determine their at-risk status. So in this group, the greens are the controls, the reds are people with an intermediate allele, so that's repeat lengths of between 27 and 35, and then the affected or the gene carrier group are over 35 repeats. Now, when you compare the gene carriers to the control group, they had higher rates of motor and cognitive symptoms. So this is a big sample, so you're going to pick up small effects. But they also had a wide range of psychopathology, mostly covering the common domains that one might expect from the earlier epidemiological work. So they had higher rates of apathy, depressed mood, anxiety, perseverative type symptoms. What is striking about this is they had 50 intermediate alleles, 50 people with intermediate alleles. In that group, they had higher rates of apathy and suicidal ideation on the UHDRS, but they did not have any motor or cognitive features. So I would contend that actually the psychiatric symptoms are the core feature of HD, which is a contentious statement, I know, from a neurologist. So that raises the prospect that actually, you know, if HD affects particular areas of the brain, do they differ from the psychopathology that you see in the general population? So just as an overview, this is a slide stolen from the research domain criteria. So some people might be familiar with this, but many won't. So the research domain criteria is an initiative by the NIH in the US to try and categorize at many different levels the kind of domains that might contribute to a whole breadth of psychopathology. So negatively valent symptoms such as response to acute threat or fear, but then that occurs at both an animal model levels, so fear extinction and things, and also imaging evidence, looking at the involvement of the amygdala and things like that. And depression, which I'm going to come on and talk about shortly, is broadly thought on these criteria to arise from an excess of negative valence and a deficit in the positively valenced sorts of aspects of psychology. So I chose to focus on depression in this talk, even though some of my research has covered some of the different symptoms, partly because it's very common, but also because it's got enormous effects on quality of life. And also from the work that I've just presented, depression in HD is known to be a direct effect of HD neuropathology. So the aim of this data is drawn from my doctoral work. So the aim of it was to use a neuropsychological task battery to determine the cognitive mechanisms based on the RDoC that contribute to depression in HD. So I recruited 51 gene-positive adult patients and 26 controls, included a medical history which included drug treatments, verbal fluency, and a motor assessment. Everyone completed the hospital anxiety and depression score, but also measures of apathy and other psychopathology with the PBA. And then I put together a task battery based on the RDoC criteria of positive and negative valence. So I tried to cover a number of different subdomains within that. So I included assessments of motivational anhedonia, so that's effort for reward. I used a task of learning from reward and punishment to see if they learned much better from punishment than from reward, which is what one would expect in the general population who are depressed. I included an assessment of consummatory anhedonia, so that's pleasure. And then included a novel task looking at response to negative outcome, which Trevor Robbins and others have shown is highly associated with depression. So they have heightened response to negative outcome. And in the analysis section, I included all of the potential relevant confounding variables to see if they influence the outcomes. So what I found was on this measure of motivational anhedonia, which is the reward reaction time task, that reaction time shortened with increased reward across the whole group. So I should say at the outset that reaction time was included as a cofactor in the model because of the potential disease burden. HD cases were slower than controls overall, even after correcting for that motor factor. But most significantly, within the HD group, HAD's depression score slowed reaction time for reward. And also importantly, there was no effect of apathy on this measure. Then looking at learning from reward and learning from punishment, there were no group differences between cases and controls on reward learning, and nor within the HD group was there any influence of depression score. But importantly, HD cases had worse punishment learning scores than controls, and this aspect was associated with the apathy scores in the HD group. I didn't find any differences in terms of experiencing pleasure, so the reward scale. And in the response to negative outcome, which one would expect to be higher in depression, although HD patients had lower estimates than controls, this didn't show any association with depression scores. So my conclusions from this are that, yes, depression in HD does differ from the sort of profile that one might expect from depression in the general population, and that the differences that we see are in keeping with the known neurobiology of HD. As has already talked about, the insensitivity to emotional faces, but people have also shown deficits in punishment learning before, so that's in keeping with what we know that HD does to people's brains. So that led on to saying, actually, if the biology is different, should we be thinking about different treatments, really? So there's a lack of RCT data. I've already said that, the one paper that we had excluded people with depression at baseline. What we do have is this large observational data set in RULE-HD. And so I came across this approach called propensity scoring, which is magic, as an alternative approach to using RCT data when in a rare disease. Sorry, I skipped on a little bit too early. So what propensity scoring does is it looks at the probability of being assigned to a treatment and then looks at what variables within the data set contribute to people being treated. So you might expect that someone with a history of suicidality might be more likely to be treated when they present with depression, for example. So it included all of those things in a model, and then inverse weights that, includes it in a model of treatment outcome to try and correct for the known variables that might affect it. So in this analysis, I included all adult gene-positive HD subjects started on an antidepressant medication for a depressive indication. And the intervention then was which antidepressant class is best. So I included, I'd separated out some things in a way based on the published guidance. So SSRIs are things like fluoxetine, SNRIs, I think most people, or most psychiatrists would know, like venlafaxine, tricyclics, but I separated out mirtazapine and related antidepressants under the tetracyclic group, phenylpiperazines as well, partly because those two classes are thought to be very beneficial for sleep. I took out bupropion and included that as a noradrenergic dopaminergic reuptake inhibitor, partly because of the bupropion trial for apathy, and then included everything else as the unique class, as a kind of a rag bag. And then the outcomes were depressed mood, so either had score of over 7 or severity and frequency PBA depressed mood scores of over 1, both at the first follow-up and then at all subsequent follow-ups as a parallel for an attention to treat process. So in terms of the methods, I've covered roughly what propensity scoring is, and I used Beth Ann Griffin's packages in R, which are great. In terms of the variables potentially influencing it, I included age, sex, psychiatric history, as well as antidepressants, comorbidities, and then in a doubly robust process, you check that your propensity scoring has worked and include any variables not completely equalized afterwards in a model of treatment efficacy. So first of all, this is just the bare outcome results. So 37% of people received an antidepressant for depression in HD. And the outcomes were higher in so the pink people are the people who did better and weren't depressed at follow-up, and the blue are the people who were depressed at follow-up. So you can see that being on an SSRI or an NDRI, bupropion, was associated with a better outcome, but was it significant? So if you look at the lower half of the table, because that's the more relevant bit, that's the doubly robust corrected bit, this is comparing treatment to being on an SSRI. And looking at the probability of depression outcome. So a negative sign is good because it means you're less likely to be depressed, whereas a positive sign is bad. So in the estimates, if you have a positive estimate, that suggests you're more likely to be depressed at follow-up. And you can see in the doubly robust model that you're more likely to be depressed at follow-up compared to being on an SSRI if you're treated with an SNRI, such as venlafaxine, or one of the unique agents. And this is across all follow-ups. And actually, this is where it starts to get really interesting, and you can see that being on an NDRI at trend level is associated with lower levels of depression. But again, this finding that SNRIs tend to be associated with worse outcomes is replicated in this data set. And this is really striking because, so this is a meta-analysis performed by Cipriani and colleagues looking at depression in the general population. And here, you can see that your big hitters are predominantly drawn from SNRIs and TCA classes and TICAs. So amitriptyline is a TCA, mirtazapine is a TICA in my classification, and duloxetine, venlafaxine. And if you look at the majority of SSRIs, so the commonly prescribed drugs in the Enroll-HD dataset, so sertraline's mid-rank, citalopram and bupropion are near the bottom. So actually, depression in HD seems to be really quite different to what one might expect in the general population. So in summary, we know that HD affects regions of the brain that directly affect emotion and cognition. We know that HD neuropathology directly causes neuropsychiatric disorders, and it isn't just an effect. It's not to discount the effect of environmental problems. Perhaps what might be news to a lot of people is that actually mental health and behaviour are the most sensitive domains to CAG repeat expansion. And then finally to say psychiatric disorders in HD are associated with different mechanisms than those in the general population. And also that the efficacy of antidepressants also differs from that seen in the general population. recommendation. So thank you very much to people who funded it.
Thank you so much, Duncan, for this.